Hello, my name is Austin Nguyen, and I'll be doing my presentation over herpes zoster, or also more commonly known as shingles. So to kind of get started, some background of herpes zoster. It is a viral disease caused by the reactivation of varicella zoster virus, or also known as VZV. It is just the same virus that does cause chickenpox. And while many people do think of shingles as just a simple rash pain, it is actually a strong example of how the immune system, virulency, and aging all interact together. So again, herpes zoster has been known for centuries as a painful blistering rash that follows a nerve pathway. The word zoster does come from the Greek word belt or girdle, which also describes like the band-like pattern of the rash. So if you look to the right, you could kind of see like the little band, like, and then the word herpes does refer to the spreading nature of the skin lesions. And for a long time, shingle and chickenpox were thought to be two completely separate diseases. However, in the 1950s, researchers have confirmed that both conditions are confirmed or are caused by the same viruses, which is VZV. And then after someone recovers from chickenpox, the virus does not fully leave the body. It does remain dormant or inactive within the body, or more so inside the sensory nerve ganglia for life. And these are nerve clusters, or they are nerve clusters near the spinal cord and cranial nerves. So later in life, especially when immunity weakens due to aging or immunosuppression, the virus can reactivate and cause shingles. And a major advancement in prevention came with vaccines such as Zostavax, which was introduced in 2006 and followed by a more effective vaccine, also known as Shingrix, in 2017, which is a little more modern one, and which is now the more preferred vaccine for prevention. So I did include a little taxonomy and a little nomenclature for the herpes zoster. I'm not going to go into everything, but I just kind of included this slide just so if anyone is curious, just on the foundation of it. So some infections and symptoms. So shingles does occur because of the reactivation of VZV, not because it is a new infection. The virus does stay dormant, mainly in the dorsal root and the cranial nerve ganglia. And when cell-mediated immunity weakens, especially in older adults around 50 years old, the virus does reactivate. And the hallmark symptom is very painful. It also follows a unilateral vesicular rash that follows a dermatomal pattern, where and or dermatome is really just like an area of the skin that is supplied by the spinal nerve, which is why the rash appears on only one side of the body rather than like the whole whatever. And then it follows like a stripe-like pattern. And then other symptoms are also fever, headache, fatigue, sensitivity to touch, swollen lymph nodes, and then a more serious complication is post-herpetic neuralgia, which is also known as PHN. It's just a long-term nerve pain that can continue even after the rash disappears. So, yeah. And then we have detection and indication. So diagnosis is really often made visually because the rash has a very characteristic appearance, as you kind of saw in the previous photos. And I feel like doctors usually look for the unilateral vesicular rash in a dermatomal pattern. However, I feel like what's more accurate for the diagnosis is laboratory testing. So the most accurate is PCR, and basically that just detects VZV DNA from any of the lesion samples. And then we also have another method called DFA. That just really just helps identify viral proteins, but really, again, like what I said, PCR is generally more preferred just because it is more sensitive and reliable than the other ways. And then we have treatment and prevention. Treatment really just focuses on reducing the symptoms and shortening the illness and preventing any other further complications. So the main treatment is antiviral medications such as, acyclovir, valacyclovir, and famciclovir. They're best used whenever the rash is started within the first 72 hours of the appearance. But again, like that's usually just like a little baseline of it. But really these drugs just really help reduce the viral replication and then shortening like the disease duration of it. And also, like what I mentioned earlier, it can also lower the risk of PHN, which is that chronic neuropathic damage as well. So, also prevention, we have nerve pain medication, we have NSAIDs, corticosteroids, gabapentin, pregabalin. Um, each of these are used just depending on the severity of the pain. And then for prevention, obviously, like the most important is vaccination, in my opinion. Shingrix is the recombinant Zoster vaccine, and it provides over 90% protection against shingles, which is why it's the most preferred today. So also like it is very recommended for adults over the age of 50 and any like other patients that may be immunocompromised or suppressed. So a little pathology and pathogenesis in this. The pathology begins when the latent VZV reactivates inside the dorsal root or the cranial nerve ganglia. And once it is reactivated, the virus does begin to replicate in the nerve tissue. So this really just causes like inflammation and nerve damage, which can contribute to severe pain and lead to PHN. And the virus then travels along the peripheral sensory nerves towards the skin, as we can kind of see in this picture. It's just reaching towards the skin, and as it reaches the skin, it does cause the vesicular rash. And patients do describe like the symptoms as like burning, tingling, and severe neuropathic pain. And even like before the rash even disappears, like they still feel those symptoms as well. And this really explains why shingles is really just considered both a skin disease and a neurological disease. So for transmission for shingles itself does not spread from person to person as shingles. It only occurs when dormant VZV reactivates inside someone who previously had chickenpox. So, however, like active shingles lesions can transmit the virus through direct contact with fluid inside the blisters. But if a person has never had chickenpox or never received the chickenpox vaccine, exposure can cause them to develop chickenpox and then not shingles. So I think this is like a very important distinction, especially because transmission is less common than chickenpox, and that is also because shingles lesions are localized and do not usually spread through respiratory droplets like primary varicella infection does, just like chickenpox. And then some major pathways. The major pathway does begin with chickenpox infection. After we recover from that, the virus becomes latent in the nerve ganglia. And as immunity weakens over time, especially the T cell immunity, the virus can reactivate. This can overall lead to a viral replication, nerve inflammation, and damage overall. And the result in shingles, or this would result in the shingles rash along with significant nerve pain, just like PHN. And this pathway really just shows how cell-mediated immunity is the key protective factor against reactivation. So again, it is not really just about the exposure to the virus. It is more so the immune system's ability to keep it suppressed. So we have the innate immune response. It responds first when VZV is reactivated. The cells do recognize that the virus is using PRRs. These receptors trigger the release of type 1 interferons, especially IFN alpha and IFN beta, as I have here in this image. These interferons really just show like how slow the viral replication are and alert nearby cells. Um, and inflammatory cytokines, such as IL-1 and IL-6, and then TNF alpha are also released. And basically, all that does is just recruits any of the other immune cells like natural killer cells, macrophages, and dendritic cells. So, really, it just helps control infection early before the adaptive immune system can really like fully activate. So now we have the adaptive immune response. So this is especially important whenever it comes to controlling shingles. So we have the cell-mediated immunity. I feel like this is a very critical part. We have CD4 plus T cells that coordinate the immune response and activate macrophages. And then we also have CD8 plus T cells that directly kill infected cells. Strong T cell surveillance, it does keep VZV dormant. And then when T cell immunity does decline, with age or immunosuppression, the virus can escape and reactivate itself. So the contribution of like the humoral immunity, we have B cells that produce IgG antibodies that neutralize free viruses and can limit the viral spread as well. But I think like it's very important to also know that these antibodies alone cannot prevent the reactivation itself. So I feel like this is why shingles is very strongly associated with declining cellular immunity rather than just a low antibody level. So we have incidence and prevalence and outbreaks. So in the United States, there are about 1 million cases of shingles each year, and approximately 1 in every 3 people will develop shingles in their lifetime. So there is a risk that is significantly, or risk would increase significantly as cell-mediated immunity declines with age. So around 10 to 18% of patients would develop post-herpetic neuralgia. And unlike chickenpox, shingles does not cause large community outbreaks. It is resulted from reactivation of latent viruses rather than just a new infection. So vaccination with Shingrix has significantly reduced disease rates. It does provide over 90% protection, making it one of the most effective prevention strategies out there right now, especially modern day as well. So some future efforts as well. I feel like it is very focused on stronger prevention and earlier treatment. I feel like one major goal is increasing vaccination rates with Shingrix, especially among older patients or individuals or any immunocompromised adults as well. Future vaccines may provide longer lasting immunity, fewer side effects, and maybe even easier administration, such as like a single dose option. But I feel like, or after doing some research, I've seen that scientists are also developing newer antiviral drugs that may work faster than acyclovir or valacyclovir, and honestly, just to reduce the nerve damage and chronic pain faster, or prevent it from even happening at all. And I think interestingly enough, from what I've seen, newer studies did suggest that shingle vaccinations, it reduced the risk of dementia and cardiovascular disease, and also biological aging, which I found extremely interesting. Like, I just didn't expect that. And then this also means that herpes zoster prevention may become part of overall healthy aging and chronic disease prevention, as it's just not just a normal just infection control. And yeah, here's just my references, but basically in conclusion, herpes zoster is much more than just a skin rash, you know. I feel like it really demonstrates how viruses can remain dormant for decades and reactivate when immune surveillances decline. And the disease does highlight the importance of cell-mediated immunity, especially T cell function, especially in preventing viral reactivation as well. And I feel like really just understanding like shingles also shows like how vaccination can prevent not only infection but also like severe complications like PHN. So I also firmly believe that, as medicine advances, better vaccines and treatments will constantly improve the prevention and quality life of patients. So, again, thank you guys for listening, and excited to answer y'all's questions in class. Thank you. Bye.